BMI, and then the issue of loss. And the magnitude, large magnitude loss, 20% is a very important prognostic factor for anybody at any body weight. So 20% weight loss, what is in the common toxicity criteria as grade 3 weight loss, is something everyone should pay attention to. But the other thing, and the last thing you need to pay attention to, is to connect up the dots. And there's a real pitfall in that. You can see a patient today and inquire about their weight loss in the recent past or since last time you saw them. But then that disappears. They'll go and see someone else or come back to see you at a later time. Unless you can take the thread of the entire trajectory of their weight loss, they may have lost cumulatively over time, 5%, 10%, 15%. I don't know how much percent, but it falls outside of your knowledge of that patient. And it's like spending. Is someone spending all their money over time? If they continue to spend, they will run out.
I'm sorry, but I might just ask, going back to our definition. Okay, so where does the whole issue of an underlying disease come in? Does that underlying disease have to be there, or can one have a person that had cancer and that has a small volume of disease and yet have profound sarcopenia, or have somebody with a large amount of disease and have minimal sarcopenia? And then, as well in the definition, do we include this whole inflammatory production of pro-inflammatory cytokines as mandatory in calling this cachexia?
The definition of cachexia, as opposed to protein-calorie malnutrition, for example, is that there is an underlying disease. So you cannot have cachexia without having cancer or chronic obstructive pulmonary disease or chronic heart failure or chronic renal failure. That is the defining term.
So there must be, you still have visible disease. It's not somebody that had a breast cancer and the breast was removed, she got a chemotherapy, and now she's losing profoundly, and we think that this is due to cancer, and yet we don't see any cancer. So there must be some visible cancer going on.
If there is underlying weight loss, there is underlying disease. So if there is weight loss which is unintentional, there is something dreadfully wrong.
So it's unintentional weight loss?
It's unintentional.
Because very often, I mean, as a medical student, you're taught if a person is losing weight, you look for hypothyroidism, you look to see that they haven't got diabetes, you look to see that they're not depressed, and you look to see if they don't have cancer.
That's right.
And very often you don't find the cancer when the weight loss can precede the actual diagnosis of that cancer.
There may be another underlying condition. It doesn't have to be cancer. The way we think about these things is guided by our understanding of energy balance. A healthy young man, such as yourselves, would normally consume at least 1 million kilocalories of energy in the space of a year, and 10 times that much in the space of a decade. Yet there is no evidence that any excess energy intake takes place over usually some of these long periods of time. In fact, even if some extra energy is taken in, it's not retained in a substantial quantity. Yes, we have modifications of weight, but it's really real testament to the close adjustment of energy intake with energy output that we do consume a million kilocalories of energy in the space of a year and manage to stay near perfectly in energy balance. Now, everybody knows this. You try and get yourself in negative energy balance, and people are thinking about this in terms of weight loss. I like to lose a kilogram of fat. How easy is that to do? It's best part of impossible for normal, healthy people to lose weight voluntarily, because all the checks, stops, and controls that guarantee that we get enough food to meet our energy outputs. And and given how difficult it is to lose weight when you wish to do so, if you start doing so when you didn't wish, it means that something is fundamentally absolutely wrong with the way your body is managing its energy inputs and outputs. You've got a disease. It could be a metabolic disorder. It could be a variety of conditions like cancer. It can also be a psychological or psychiatric illness resulting in this loss of control of energy balance.
Now we see cachexia as well, or severe weight loss, or sarcopenia, in patients with end-stage lung diseases, end-stage heart diseases, other chronic illnesses, tuberculosis, dementia. What are the common pathways between those illnesses and cancer? What is it that makes that process the same? I guess another way of asking
the end result, the pathogenesis.
I guess we're asking the question is, often when patients and families ask me, why am I losing so much weight? Until now, I've been explaining to them, well, it's because of the inflammatory process, the cytokines that get produced by the cancer and by the interaction of our immune system and the cancer. Produces all these cytokines and changes the metabolism. The metabolism becomes very rapid. One loses a lot of proteins, and therefore you lose a lot of weight. Is that true? Do I need to start changing what I'm saying? And can I say the same thing for someone who presents with cachexia and has end-stage heart disease, end-stage lung disease?
Yes and no.
Okay.
I think you're right. The point where the cachexia experts across all the different diseases, from AIDS, lung diseases, renal failure, chronic heart failure, all these different diseases started putting their heads together, they realized that inflammation is the common thread of all of those things. And there is an underlying inflammatory process systemically or at a given site in all of those conditions. And it's as simple as this, and goes back to, probably you've known this for about 30 years, that when you have inflammation, inflammatory mediators like cytokines and eicosanoids, so prostaglandins and such, talk to skeletal muscle and adipose tissue, and the message they give is break down. So by receptors for those molecules, those tissues receive a message, and the message is to break out the content of those stores. So to release energy fuels from adipose tissue, to release amino acids from muscle, which is not an irrelevant message, except if the release of those things is uncontrollable and the quantity of breakdown is out of proportion.
It's almost like turning on a tap and putting on a plug.
Exactly.
So you can never fill. You can never have enough. The muscles breaking down and gluconeogenesis can never provide enough fuel to satisfy what the body needs, almost. So just as the more they break down, the more it's wasted.
From this comes the notion that you would treat wasting syndromes with anti-inflammatory therapies, be they nutritional or pharmacologic. So to manage inflammation as best as possible to hold that down.
So does that mean that family physicians should considering using a non-steroidal anti-inflammatory?
Well, there is evidence that the COX-2 inhibitors may be having an effect. I mean, there is evidence on this now.
Is that something you feel that should be in practice now, or is that something that it's experimental, it's still being researched?
I think it's been shown, but it needs to be verified before you can really go and say that that would be the standard of care. I mean, but there is certainly evidence coming out from Europe that the COX-2 inhibitors do have a role.
Because we see this in daily practice, right, where families will say, I'm losing a lot of weight, I'm going to be starving, can you do something about it? Don't allow this to happen.
You can check the patient to see if they have inflammation by ordering a blood test for C-reactive protein. And if it is higher than 10 or higher than 50 or higher than 100, you have a scale of understanding of how bad the level of inflammation the patient has. They could have no inflammation, or that's to say their weight loss could be driven by other things. But you can assess for inflammation. And then Martin is right. There's practice and practice. In worldwide clinical practice, patients are not being systematically treated for inflammation to manage involuntary weight loss. Yet if you go to a number of places where there are specialized clinics, and I think this is also an important point, in the certain cancer centers, like the MD Anderson Cancer Center, or in certain parts of Canada, like in Montreal, in the, I guess, what is the name of the clinic? It is the
Cancer Nutrition and Rehabilitation Clinic.
The Cancer Nutrition and Rehabilitation Clinic. In those kinds of highly specialized units, focusing particularly on this problem, management of inflammation is a matter of course.
Can I just comment that, you know, using family physicians and clinicians in practice would be quite apprehensive about using non-steroidal anti-inflammatory drugs. There are multiple side effects. And I would just maybe put it to yourself and to Martin to comment on the level of evidence that there is available to us. I mean, as far as I know, there have been some comparative studies, but is there sufficient evidence there to say to a family physician that you should perhaps consider prescribing?
Well, you see, I mean, if you take the big trials really, and it's still ongoing and almost finished by Mantovani. I mean, and he wasn't just looking at anti-inflammatories. He's putting a whole concoction of things together.
Yes. Yeah.
Okay, and it does look at, you know, there were five arms in that study. And it did look like the arm that with the COX inhibitor, patients did do better. But that needs to be verified. There is a light over there, and it does look important. But as you say, there are side effects, and there's been a lot of side effects with the COX-2 inhibitor. So just to prescribe it, you know, and to say, well, it may help, is not correct.
Yeah.
And yet there are other people that believe that the carcinoids, the vitamin E derivatives, are very anti-inflammatory if taken in high enough doses, so that could work as an anti-inflammatory drug. And then, of course, there are other people that